Good afternoon, ladies and gentlemen. It's an immense pleasure to be here this afternoon for a number of reasons. First of all, I live and work in Canada, and Canada in January does have some limitations. So having a chance to leave Canada and particularly come to one of the world's great cities in Barcelona is an immense pleasure. So thank you both for allowing me to join this afternoon. I want to begin by sharing with you my potential for conflict of interest with advisory boards, speakers' fees, grants and aid, and my employer is McMaster University. I want to begin my presentation this afternoon by giving credit to two quite remarkable people. Dr. Suzanne Hurd and Dr. Claude L'Enfant, who a little more than 25 years ago had a concept, an idea of developing a document that could be useful and used worldwide to help improve the treatment of asthma. And just last year in the ERJ, together with some colleagues, we wrote a brief history of this document, this group that became the Global Initiative for Asthma. The really clever idea that Drs. Hurd and L'Enfant had was to develop a document, a strategy document, that had the best quality evidence for management, for diagnosis, treatment of asthma, but make it available in such a way that it could be used in many different countries. Countries such as Spain or Somalia, Canada, or the Cameroon. Countries with very different healthcare systems, very different access to medications, but still this document would be useful in developing recommendations around asthma management. And GINA is now, for asthma, is now a control-based management cycle where the patient is assessed, the diagnosis is established, symptom control risk factors discussed, technique and adherence discussed with the patient, and patient preferences discussed. And then treatment is adjusted, not only the medications, but non-pharmacological strategies and modifiable risk factors. And then the patient is reviewed, assessed, and treatment is adjusted. So this becomes a positive, iterative loop of asthma management. Now, the specific question that Alvar and Bart asked me to speak on today is as needed versus continual treatment for patients with asthma. And if I look back just a little bit, just 2 years ago to 2018, this is what the summary of the GINA recommendations looked like. This is the positive iterative loop I've talked about, and you'll see there are 5 steps of treatment based on the amount of treatment needed to control the disease. You'll notice the primacy of inhaled corticosteroids throughout the strategy document. And even in patients with very mild intermittent asthma, patients with symptoms even as little as 2 days per month, the recommendation was to consider inhaled corticosteroids as maintenance. 2018, the answer would have been very simple. All patients with asthma, even those with relatively infrequent symptoms, should be treated with regular maintenance inhalers and short-acting beta agonists or low-dose inhaled steroids with a rapid onset beta agonist considered as the reliever option. Now, there's a problem inherent with this strategy and with the recommendations about using maintenance treatment for all levels of asthma. And that problem is very nicely demonstrated in this study. It's an old study, 2006. But it's a study of a very effective combination treatment for asthma, fluticasone and salmeterol, which is given twice daily. This is a study from the United States, from a HMO organization in California, where prescriptions were followed very carefully in more than 5,000 patients with asthma in whom this treatment was recommended. And you'll see, to get into the trial, every patient had to fill the first prescription. At 1 month, 40% of patients fill the second prescription, and by the end of 1 year, about 10% of patients had filled prescriptions to take the medications as prescribed. This is the single major reason for poorly controlled asthma: lack of adherence and lack of persistence with taking the medications as prescribed. And this is true across the entire spectrum of asthma, but particularly so in patients with infrequent symptoms. Patients feel well most of the time. They do not choose to use a regular maintenance medication to treat their disease. And in this study, younger patients were more likely to stop taking medications. This surprised me. Women were less adherent than men. Now, I have been told my entire life that women were better than men in every aspect of life, but clearly not this one. No previous use of SABA, other medications, and higher co-payment put patients at risk of poor adherence. As a result of this, short-acting beta agonists, SABAs, remain today the most widely used asthma medications worldwide. And this is despite the fact that we've known for almost 30 years that regular use of SABAs, in these studies 4 times a day, for as little as 1 week of treatment, actually worsens asthma control, makes exercise bronchoconstriction worse rather than better. This study is done in my lab a number of years ago, and actually promotes allergen-induced airway inflammation, eosinophilic airway inflammation. 1 week treatment 4 times a day make all of these outcomes worse when compared to 4 times a day treatment with placebo. And we've known again for many years that overuse, very frequent use of SABAs, is associated with increased asthma mortality. So despite this evidence that SABAs, when used frequently, actually make many markers or outcomes in asthma less good, they still remain, in 2020, the most widely used medication for asthma worldwide. So this begs a question: is there any benefit to using a reliever medication which contains both an inhaled steroid and a rapid onset beta-2 agonist? Patients with asthma must have rapid relief of their symptoms. And we know that a beta agonist will usually provide that. So what about every time they use a rapid onset bronchodilating medication, they also get a small dose of inhaled corticosteroids? Well, there are studies that go back more than 10 years, 13 years. This study was published by Alberto Papi and his colleagues in Italy, called the BEST trial, published in New England Journal of Medicine, where he tested that hypothesis by comparing, in patients with milder asthma, as needed albuterol, the SABA, salbutamol, Ventolin, to regular combination treatment with beclomethasone, a regular combination with beclomethasone, albuterol, regular beclomethasone, or an as-needed combination that contained both the steroid beclomethasone and the rapid-onset beta-agonist salbutamol. So they only used it when they were symptomatic. And the outcome shown on this slide is asthma exacerbations, severe events that require oral corticosteroids or visit to a hospital emergency room or hospitalization. And the risk of an event was greatest with the as-needed albuterol and was least when the reliever medication contained an inhaled steroid. So the time to first exacerbation was shortest with as-needed albuterol. Reliever use was higher with as-needed albuterol compared to beclomethasone maintenance, but there was much lower inhaled steroid needed when compared to regular beclomethasone and the as-needed combination treatment. Now, that study was a relatively small study, 600 patients or so, with a combination beclomethasone, salbutamol, that's not widely available. It was available in Italy at that time. I don't know if it's available in Spain now, but generally speaking, not widely available. So it was for that reason that two large studies were conducted called the ASTHMA trials. Each study, approximately 4,000 patients. Patients selected to have mild asthma, but with symptoms frequent enough that according to the GINA recommendations, they should be treated with maintenance inhaled corticosteroids. And so in each of these two studies, the gold standard treatment was beclomethasone, 200 micrograms twice a day, with the SABA as needed as reliever, compared in ASTHMA-1 to just the SABA alone as needed, and to the combination budesonide formoterol as a reliever medication. So we had the gold standard compared to what patients almost always do themselves, which is to stop taking the steroid and just rely on the SABA, and then the ICS-LABA combination as needed. ASTHMA-2 was exactly the same design, except it did not have a SABA-only arm, and it was more pragmatic design. Only 2 mid-trial visits, there was no daily diary, no monitoring of peak flow, and no medication reminders, where that was all part of ASTHMA-1. Patients were reminded every morning and night to take the maintenance medication, and they had a diary, electronic diary, to fill in every morning, every night. And every time the medication was used, either as a maintenance or as a reliever, it was measured electronically. Patients were almost identical in the two studies, around 40 years of age, mildly uncontrolled asthma, an ACQ score of 1.5, so very mildly uncontrolled. FEV1, 85% approximately predicted, and there were 2 different subgroups. 45% of the patients were admitted uncontrolled on a beta-2 agonist and therefore should be managed with an inhaled corticosteroid. And little more than half were controlled on an inhaled steroid and therefore, according to guidelines, could be stepped down to just a beta agonist as needed. But importantly, although every effort was made to find patients with mild asthma, about 20% of the population had had an exacerbation in the previous year requiring oral corticosteroids or a hospital visit, emergency visit. For ASTHMA-1, the primary outcome variable was the percent of well-controlled asthma weeks. The blue bar is the as-needed SABA. The red bar is the as-needed or reliever ICS-LABA. And these differences were significant. So just switching the reliever from a SABA to an ICS-LABA slightly improved the percentage of well-controlled asthma weeks. But still, it was less than 40% of the weeks during the 1 year of the study were well-controlled weeks. Well-controlled weeks were weeks when the patient was perfect. No symptoms, no reliever use, absolutely perfect, and normal peak flow during that week. But the maintenance inhaled steroid with a SABA as needed was significantly better than either of the 2 reliever arms. And that's as it should be. These patients were chosen to be patients who would benefit from inhaled steroids. We've known for 30 or 40 years the benefit of regular inhaled corticosteroid use, and here it is, just confirmed. And in the two subgroups of patients, the results were very similar. But the really important information in this study is shown in this slide, because this is the exacerbation rate per patient per year. The patients treated with the SABA as reliever, the rate was 0.2. About 20% of the patients had a severe exacerbation during that year. Switching to the reliever with an inhaled steroid, it was reduced to 0.07, or about 7% of patients. And with the maintenance inhaled corticosteroid, it was 9% of patients. And for moderate or severe exacerbations were events that required an increased amount of inhaled steroid, 0.36 to 0.14 and 0.15. In STHMA-2, there was no terbutaline or SABA arm, so the comparisons were the as-needed budesonide formoterol to budesonide maintenance, and the exacerbation risk was essentially identical. And that was the same in the two subgroups of patients. But importantly, in both of these studies, the amount of inhaled steroids that was needed was 340 micrograms with the maintenance budesonide, and that was reduced by more than 80% with the budesonide formoterol as reliever, and a 75% reduction in STHMA-2. And that was because in these studies, the adherence rate was extremely high. More than almost 80% in STHMA-1, where there were reminders sent to the patients, and a little more than 64% in STHMA-2. So an obvious question that comes from these two large studies is that the use of SABA for symptoms increases when patients are symptomatic as an exacerbation of asthma develops. More symptoms, more SABA use. The exacerbation is identified, treated with usually oral corticosteroids, and it resolves. Is it possible that using these very low doses of inhaled steroids as the exacerbation gets worse is the reason for this reduction in risk? Well, in STHMA-1, we could try and answer that question because every actuation of the inhaler was measured, and we knew when patients had severe exacerbations. So we looked at the relationship or associations between using a reliever and then the subsequent risk of a serious event over the next 3 weeks after any day when a patient needed more than 2 reliever uses on any day. And this is what the reliever use looked like. As needed terbutaline, it was only 0.58 actuations per day, 0.47 with the as-needed budesonide formoterol, and 0.39 with maintenance budesonide. So patients on average needed 1 puff of a reliever every second day through the study. But of course, it was a very skewed distribution because on more than 70% of the days, the patients didn't need any reliever medication, and using 6 or 8 inhalations on any day was extremely rare. But we had the information, so if you look at the relationship between using at least 2 reliever medications on any day, what happened, what was the risk of an exacerbation over the next 21 days? There were 936 patients had such an event with terbutaline, and 4% of these had an exacerbation. 850 with as-needed budesonide formoterol, 1.2% had an exacerbation, and with maintenance budesonide, 758, 1.5%. And those are the statistical comparisons of the risk of an event after using at least 2 reliever medications on any day. If you look at 4 or more, this is the risk. It's almost 8% with tributylene, 1.7% with as-needed budesonide formoterol, and 2.9% maintenance budesonide. And again, these are the comparisons. 6 or 8 on any day were very rare, and so the statistical comparison is much more difficult than these more frequent events. But these are the data about an 8% risk with tributylene. Of the 102 patients with as-needed budesonide formoterol, only 1 had an exacerbation if that individual used 6 or more inhalations on any day. And of the 49 patients who used more than 8 inhalations a day, not a single one had a severe exacerbation. And so these data, at least I find very compelling to suggest that it is the introduction of very low doses at the right time, as exacerbations are developing, reduces this risk of a severe event developing. Now, since those 2 studies have been published, the ASTHMA trials, there have been 2 other studies reported this past year, 2019. Both of these are pragmatic clinical trials. They are randomized but not double-blind, so the patients and the physicians knew the medication allocation. But the treatment groups were the same: albuterol or salbutamol as needed, budesonide maintenance, the gold standard, and then budesonide formoterol as needed. And this is the annualized exacerbation rate. You can see there's a very similar reduction to the ASTHMA trials, about a 50 or 60% risk reduction. But for severe exacerbations, for the first time, the maintenance budesonide group did not look any different to the albuterol group. But the budesonide formoterol as needed group was significantly less risk. Now, I don't know the reason for this, but I suspect it's because in pragmatic studies, in contrast to double-blind randomized clinical trials, adherence to the maintenance treatment is less good. And adherence was measured in a small group, 10% of these patients. It was pretty good in that group. But overall, in the population, I suspect that's the main reason that the maintenance budesonide group did not look any different to the as-needed SABA group. But I have no proof of that. That's just one relatively simple explanation. But in this study, they also measured exhaled nitric oxide as a biomarker of inflammation during the study. The concern being that if you don't use a maintenance inhaled steroid, you allow inflammation to gradually get worse over a 1 year of study. Now, that doesn't make much sense to me, because eosinophilic inflammation, if it is getting worse, is associated in every study I'm aware of with an increased risk of an exacerbation, not a reduced risk. But still, they measured FeNO, and you can see in both of the steroid arms, the maintenance budesonide in red and the budesonide formoterol as needed in blue, there was a reduction, a significant reduction in FeNO, which was not seen with SABA, and that persisted for the duration of the study. So no evidence that inflammation was actually, as measured by this biomarker, was getting worse through the study. And the final study I want to share with you is this study published in The Lancet just in the past few months, which was the same as ASTHMA-2. So in this study, there was a comparison of as-needed budesonide formoterol in red and maintenance budesonide in blue. And for severe exacerbations, once again in this pragmatic trial, the risk of a severe exacerbation was greater with the maintenance budesonide than it was with the as-needed budesonide formoterol, although the risk was small, but significantly different in this particular trial. And when they looked at predictors of response, if to the left of the line is an improvement with budesonide formoterol, virtually every single thing they could look at, it was to the benefit of budesonide formoterol, compared to maintenance budesonide. So we are now jumping from 2018, where everything was maintenance, to GINA 2019, where it becomes just a little more complicated because of the data that I've shared with you. So now, GINA is recommending that the reliever medication, the preferred reliever medication, for everybody with asthma contains an inhaled corticosteroid. And that is because for every single outcome in these 4 large clinical trials, the reliever containing a steroid outperformed SABA significantly in every single outcome. But of course, SABA is still an option because there will be many countries where the ICS-LABA option is not available, too expensive, just not viable. So you still must have a reliever for asthma, so a SABA is still there as an option. And perhaps a bit more controversially, in step 2 treatment, low-dose inhaled corticosteroids as a maintenance is still recommended. But now, the as-needed low-dose ICS formoterol is there as a choice, a recommended choice for patients with step 2 mild asthma. And this is because of the issue I started with, the fact that adherence to low-dose maintenance ICS is so poor worldwide. And what we do not want is to have patients recommended or prescribed low-dose ICS and in fact reverting to just using a SABA as needed as their treatment of choice. So I'm going to conclude, Mr. Chairman, to say that adherence to maintenance treatment in asthma is very poor, particularly in milder asthma where patients are intermittently symptomatic. SABAs remain the most widely used asthma medication worldwide, even today in 2020. Overuse worsens most asthma outcomes. Asthma reliever medications which contain a steroid are superior to SABAs for every outcome that's been looked at to date. But importantly, this treatment approach has been approved in the country where I work, in Canada, but is not yet approved here in Europe. So I want to make sure that's a caveat that you understand about these data. Thank you very much indeed for your attention.